Hello and welcome to today's webinar, Breast Pathology 101. My name is Michelle Dixon and I am the Program and Development Director for Massachusetts Breast Cancer Coalition, and I would like to thank you all for joining us today. I'm very pleased to welcome back today's speaker, MBCC's own medical advisor, Dr. Michael Misialek. Dr. Misialek currently serves as the Associate Chair of Pathology at Newton-Wellesley Hospital. He is the Medical Director of the Vernon Cancer Center, Chemistry Laboratory, and Point of Care Testing. He holds an academic appointment at Tufts University School of Medicine and regularly instructs medical students and pathology residents. He is a strong advocate for pathology and is very active in the College of American Pathologists. He is an inspector with the college and has conducted numerous hospital laboratory inspections both nationally and internationally. He received his MD from the University of Massachusetts, completed his residency in anatomic and clinical pathology at the University of Massachusetts Medical Center, and did a fellowship in surgical pathology at the University of Florida. He is board certified in anatomic and clinical pathology. Dr. Misialek, welcome.
Thank you very much for the kind introduction, Michelle, and welcome everybody. Thank you for signing up and logging in today for what I hope is an informative presentation for you. This topic on last year's presentation I did. If any of you were able to listen in on that one, we're going to take it to the next step here and find out things you need to know. Features are to look for in your report, the questions you need to know to get answered when you're talking with your care team, and at the end of it, appreciation for the doctor behind the scenes, the pathologist, the ball rolling here by making the diagnosis. So for breast pathology or any abnormality in the breast, the first thing that happens is typically there's a mammogram. And abnormality that's found on that mammogram, and some of the key buzzwords that will be on a report that it's flagging that there is potentially something here that needs to be worked up further, either with additional imaging studies or a biopsy, a tissue biopsy. And some of the common phrases you might see to the effect of a non-palpable mass lesion, which means there's a spot, an abnormality on the mammogram that isn't felt by the patient. It's too small or it's too deep, but radiographically it's apparent, and that's the value of a mammogram, is to find lesions before they to find abnormalities before they become larger or more serious. Sometimes there may not be a discrete mass, but there can be radiographic distortion, meaning there's some abnormality in the normal architecture of the breast that's seen on mammogram. And the other thing that radiologists always look for are calcifications. Calcifications can be benign, many of them are benign, but calcifications are also commonly associated with an very early type of breast cancer called ductal carcinoma in situ, and I'll show some slides on that, what that means. And that's a reason why calcifications are looked for very closely and scrutinized and determined whether they're benign calcifications or worrisome calcifications, and should they be pursued further. And the other reason why women might present for a biopsy is that they've found an abnormality during self-exam or in their primary care doctor's office. Somebody has palpated an abnormality and they would be referred to a radiologist for further imaging and potential biopsy. Here's an image of a mammogram, and at the very center, you can see here, there's a few spots, and those white spots at the center are calcifications. That's what calcifications look like on a mammogram. There's a lot of haziness in the background, and that is just the normal breast tissue. It looks sort of cloudy. There's dark areas, there's light areas, and that just corresponds to the heterogeneity of breast tissue, the proportion of actual breast tissue versus fat. And this is why some women on their reports may have a disclaimer that says something to the effect of their breasts are dense and it may obscure potential findings, and to be aware of that. And many facilities now will do 3D mammography to try and look through some of that density in the background, get better resolution, or even have a woman come back for additional imaging. They'll do magnified views of the the need for additional workup. What we see here is actually a patient who's had a biopsy, and all of those strings of tissue are core biopsies taken from the breast using a needle, and they've been laid down in the mammogram machine and imaged. And you can see some white areas within the middle, little speckling. That's calcifications, and that ensures that the radiologist has appropriately sampled the calcium that was seen on the original mammogram and has targeted it and removed it. And this all happens before the tissue comes over to the pathology lab. There's a couple of major ways in which breast tissue can be sampled. Perhaps the most common is called stereotactic. That's what the previous image was a picture of, and I'll show you what that looks like grossly. And that's a needle that's actually positioned using computer software to target in conjunction with the mammography images very precisely those abnormal regions. One can also do what's called an FNA, or a fine needle aspiration. This is where a very, very thin needle is used in the office, and it can be done under ultrasound guidance or just by palpation, and advanced into the breast with a little bit of aspiration applied, and the cells then are under the microscope. And that's sometimes done more of a triage step, whether the pathologist sees something abnormal that then needs further biopsy, or it's sometimes done with women who have benign cysts that frequently recur and from time to time need to be drained. So what happens to your biopsy? After that tissue or the fluid is removed, the biopsy comes down to the lab, and this is what they look like in the laboratory. This is those pieces of tissue that, I'm going to just click out of here so I can move my cursor. These are the little core biopsies that were taken by the needle in a patient's breast. What we do is we put them in these cassettes here, and on this little sponge so that they don't get lost. These cassettes are closed up and then put into an instrument where overnight they're fixed. They're basically dehydrated and then infiltrated with paraffin wax. And I'll show you on the next screen here what that looks like. That tissue then is embedded in paraffin wax, and it's still on the platform of that little plastic cassette. And the reason we do that is because that little cassette then gets loaded into this instrument here called a microtome. And this takes very, very, very thin slices of that tissue, which are then placed onto a glass slide and stained in an instrument here. And what we get are the glass slides here with those pieces of tissue laid out here, stained in various shades of pinks, purples, blues, and I'll take those slides, and the pathologist will put them under the microscope and will examine it histologically and see if we can find what the radiologist was looking for, to see if our findings under the microscope correspond to the radiographic abnormalities that prompted the biopsy, whether it was looking for calcium, looking for a reason that caused a mass or some other distortion on the film. Before we take a look at abnormal breast and early breast cancers, it's good to just show a picture of what normal breast looks like under the microscope. Here's a shot of normal breast tissue, and if you can see my cursor, I'm circling here what's called a lobule, and that's a collection of these small ducts. It's very orderly, uniform. They're regularly spaced. Some may even be cut tangentially like this, so you can see that that's a breast duct. And all of these different lobules are connected together by an intricate duct system that eventually feeds out to the nipple. And this is the sort of business end of the breast. These epithelial lined ducts and lobules are where abnormalities occur. That's where pre-cancers occur. That's where an in situ cancer or a bona fide invasive cancer occurs. The background material here is the supporting structure of the breast. It's fibrous tissue, it's blood vessels, and over here you can see that these soap bubble areas looking is fat. That's what fat looks like under the microscope. It's predominantly this blown up bubble-looking cell with a little nucleus here at the edge. That's the brain of the cell. And this is what gives that cloudy appearance to the mammogram, is the differing percentages of this fibrous tissue with fat. And women who are described as having dense breasts, they'll have a greater proportion of this pink, dense fibrous tissue. And radiographically, what we see on mammograms are shadows of interfaces between less dense tissue, such as the fat, and the dense breast tissue. So you can imagine if the whole thing were dense, it's going to be hard to pick up abnormalities that might be evident by obscuring some of these borders, some of the contrast between the different components of the breast. A very common change that is seen frequently is something called fibrocystic changes. Many women probably have heard that term described to them by their doctor, that they might have lumpy breasts, small cysts. That's encompassed under this broad term fibrocystic. If we break that term down, fibro means fibrous. I showed you what the fibrous pink tissue looks like, and cystic I can show you. Now this appearance looks a little bit different than the last image we looked at. Instead of being very orderly, we see some glands are dilated like this. So that's an example of a small cyst. Cysts can be even larger. They could be centimeters in size, and that could be palpable, present as an abnormality that it gets worked up further. So that's a cystic component. The fibrous are, there's often some increase in the density here, but what you'll also see going hand in hand with fibrocystic changes is something termed hyperplasia. Now, if we look back at the normal breast here, most of the ducts and lobules of the breast, they have a space in here. That's a lumen. That's what connects all of the ductwork of the breast, and it's lined by just 2 cell layers. Sometimes that first cell layer can start to divide, and when those cells divide, they pile up and they push into the interior, into the space, into the lumen of that duct, and start to crowd it and create these little outpouchings. You can see that this duct here is almost completely filled by cells, as is this one, but these over here still retain that very simple lining. This is called hyperplasia, and it's a benign change. It just means that there's some stimulation here that's causing breast tissue growth. It can be one step of the multi-step process that eventually develops into a cancer, but not all hyperplasias turn to cancer. It is considered, though, a risk factor because there is some background stimulation here that's causing cell division, and we know that persistent cell division or uncontrolled cell division can lead to a cancer down the road. But this is very common. Fibrocystic changes with what we call usual ductal hyperplasia, meaning it's completely benign, is very, very frequent. I see it daily in biopsies, and it's considered a benign finding that we don't worry about. And fibrocystic changes can cause abnormalities on a mammogram, and sometimes that will explain to the radiologists or confirm what their suspicion is, that they think this is a benign finding, and after they talk with the pathologist who confirms it, they feel that they've adequately sampled that region, and that explains those findings there. If we progress down the pathway of cells dividing uncontrollably, the next step is called atypical ductal hyperplasia. Remember that last slide here was usual ductal hyperplasia, meaning it's a uniform process, but for some reason, potentially genetic or a mutation where those cells keep on dividing, it can become atypical. And I think in this field, you can gain appreciation that we no longer have any single ducts that have an open lumen. All of these ducts have been expanded and filled with cells that are dividing, and they have very little spaces in between them. What remains are these little punched out lumens of varying different sizes. This is when we label something atypical. Now, once we've crossed the border from usual hyperplasia now to an atypical hyperplasia, that is usually an indication that something else needs to be done. Remember, we're just working on a needle biopsy here as a screen for an abnormality on the mammogram. So if I were to report back to the radiologist that I see this under my microscope, looks like atypical ductal hyperplasia, I'm going to recommend an excision so that we can look at more tissue, the tissue around this, because atypical ductal hyperplasia has a propensity to associate with other precancers and even bona fide cancers. So it's a signal that we need to look at more tissue. And that's why if a patient has a biopsy and it comes back as ADH or atypical ductal hyperplasia, we'll recommend an excision. And what would be the next step is a larger biopsy or a lumpectomy, as some may call it, where more tissue is taken out. So the next series of slides here are the reason why we like to pursue and work up calcifications that a radiologist will find on a mammogram is because, as you recall, I said that calcifications can be a harbinger of DCIS, or ductal carcinoma in situ. So if we continue along the spectrum of hyperplasia, atypical hyperplasia, and now ductal carcinoma in situ, now the cells have crossed the threshold of just purely dividing. Now we've got, you can see here that despite some of the glands being completely full, others aren't, but they have these very intricate, almost geometric looking configurations, and this rigidity of growth or appearance of these cells, this is very classic for a ductal carcinoma in situ. So this is a cancer. However, there's a lot of debate out there now as to whether this should really be called a cancer, because ductal carcinoma in situ, the in situ portion means that it's not invading, it's in situ, it's inside these ducts. It has yet to break out beyond the confines of the duct. And as long as it's in this duct, it has no metastatic potential, meaning it cannot break out and have access to blood vessels out here, which is a hallmark of an invasive cancer when it breaks out and then starts to invade out into this fibrous tissue and has metastatic potential. Then that's a truly invasive carcinoma. But at this point, theoretically, it's 100% curable. It has no metastatic potential, and often can be cured by surgery to make sure that the margins are clear, and potentially some hormone therapy or even radiation if those margins are close. And I'll show you what I mean by margins here. But just to get an appreciation for some of these different patterns of ductal carcinoma, this is a nice slide here in that it shows up in the upper portion here. These are the benign ducts that I showed you on that very first image, nice and orderly, sort of this, you can draw a circle around these. But then down here, you can see a lot of these ducts expanded. They've been distorted by this proliferation of cells. One thing I should mention back on this last slide, this is what calcium looks like under the microscope. This sort of purplish, fragmented granularity here and over here as well. So that's morphologically what calcifications on the mammogram look like under the microscope. And I will report those and say calcifications are present so that the radiologist knows indeed they did sample them and it corresponds to what they were going after. This field that I was showing here is also ductal carcinoma in situ. It's a little more florid in that the ducts are even fuller, and you can see down here too, there's those calcifications. Here's a third bit of fragmented calcium. So here's another image of ductal carcinoma in situ. This is called a cribiform pattern, meaning it's these glands within glands, and there's sort of this back-to-back appearance. But the way I think of this is it's very geometric looking. It has this sort of mosaic of open lumens here. But the reason it's neoplastic is because these cells are all fairly similar looking. They're monomorphic. They're theoretically it's a clone that has proliferated uncontrollably. So every offspring of that cell looks like the other one, and that's why we developed this monomorphic appearance of the cells. This is a little bit higher power view to show one duct that's involved by cancer. This is still in situ cancer, and you can even see some little calcifications here. So calcifications, not all calcifications are associated with DCIS, and very good radiologists can often determine just on the mammogram what benign calcium looks like versus calcium that is worrisome that there might be ductal carcinoma in situ nearby, and that's when they would recommend a biopsy or an interval study where the patient may be asked to come back in 6 months to see if they've changed any, or to see how that appearance compares with prior films. If we find a ductal carcinoma in situ, patient will often go for a lumpectomy, and that tissue comes down to the lab from the operating room. We will ink it, and you can see here that there's ink on this edge. It's some looks like orange ink, and the reason we put ink on the specimen is that so we know where the surgeon has cut, and that's a true margin, meaning that's exactly the margin that came from the patient versus us getting the tissue and then cutting it in the lab into those small pieces that then go on to a glass slide. So the ink helps us in orienting it, knowing where a true margin is, and that's very important for the oncologist, for the surgeon, for radiation oncologists. They're always wondering or asking how far is the cancer from the margin, and this is what that means. This gland here of DCIS is not touching the ink. That's probably about 1 millimeter, but you can see this cluster of DCIS is right at the ink. So this would be an indication probably to go back. Some patients, as you may know, they'll have a lumpectomy, but then the pathology report comes back and they're found to have tumor at the margin. That's what this means. There's cancer right at the ink, or very close to the ink, and that usually means we need to go back and take extra of this margin. And we know exactly which margin it is because the surgeon will very carefully ink these specimens right in the operating room with different ink colors. And it'll correspond to particular regions, such as this may be the superior portion of the specimen, or the posterior, or the anterior, or the lateral medial. So we'll report out exactly where the tumor is in relation to the ink so that the surgeon can go back and know exactly where in the patient that close margin or positive margin was that needs to be re-excised. So that was all ductal carcinoma in situ, or cancers that are just confined within a duct. If that cancer then breaks through what we call the basement membrane, or the supporting structure around the duct, and starts to invade into that fibrous tissue or fat of the breast, that's when it becomes an invasive cancer. And the most common type of invasive breast cancer is called an invasive ductal carcinoma. And this is what it looks like. So it's these little glands that may not look too different from that original benign breast I showed you, but as you can see, there's no overall structure or confinement of those ducts. They're spread across the entire tissue here. They're invading through this fibrous tissue in a haphazard pattern with ducts of differing sizes and shapes. This is a invasive ductal carcinoma. The next thing that a pathologist will do when they look at this cancer is they'll grade it, meaning how histologically, meaning what does it look like under the microscope in relation to what we think its biological aggressiveness is. And that's typically a three-stage or a three-grade tier, from well-differentiated cancer to moderately differentiated to poorly differentiated. And what I mean by that is we will look at these cells, and based on the appearance of the cell, whether we see a lot of divisions there and what percentage of actual nice open glands are here, we will score it. This is an example, and I'll show you examples of all three, and I think you'll get an appreciation. So this is a example of well-differentiated cancer. It's virtually every tumor gland here is forming a gland. Here's another one, and we can actually see how it is infiltrating through the fat, through the fibrous tissue here, and actually out into the fat. Each of these little glands here is a malignant gland that is spreading outward. And when cancer spreads through the breast here, it's viewed as foreign, abnormal by the body. The body tries to set up a response to it. It will try and wall it off by forming a lot of this scar tissue, this fibrous tissue. That can be seen on a mammogram, and that may be one of the abnormalities a radiologist will get worried about, because they see this pattern and are worried about a cancer there that may have already developed. This is one more shot of a well-differentiated cancer. It's forming open glands in virtually every one of the glands here, and that's in contrast to this. Now, this presents a bit of a different appearance in that you can still find glands here that have an open lumen or an open space, such as that, and down here, but many of them are just a solid nest of cells. This would be a moderately differentiated cancer. It's not well differentiated in the sense that it's forming very uniform glands. Here, they're becoming more, the pathologic term that we use is pleomorphic. They have various shapes and appearances. Its uniformity is disappearing. Now that is in contrast here. This is an image of a poorly differentiated carcinoma, meaning it's very difficult to find any glands here. Perhaps we see one there, but a lot of it is just a solid mass of cells, even perhaps some single cells over here, but they're having trouble forming even those rudimentary glands that we have seen in the well-differentiated cancer. And this is just a higher power shot of that poorly differentiated cancer, and I think you can see that there's a lot of size variation. Some of these cells are enormous versus some are smaller. Here's one that's even bigger. There's no order here. This is very atypical, a lot of malignant features. This is another example of a poorly differentiated carcinoma. Now, we evaluate these just like we do DCIS when there's a lumpectomy or even a mastectomy done for an invasive cancer. We will ink the margin, and you can't see the ink well here, but there is some black ink. And here's a tumor nest. There's another one here. This one isn't at the margin, but you can see this one actually is right at the margin, actually has this little bit of distortion. It looks like the cells are pulled or kind of hazy. This is some cautery artifact. As the surgeon cuts, they will use cautery or burning to stop some of the vessels from bleeding, and that's further evidence that something is at a margin, that we see this burning artifact. So this would get reported as a positive margin. I don't want you to get the impression that all cancers here are have positive margins, but I just wanted to show what positive or close margins look like, because many of you may have heard about margin issues or wonder exactly what the margin is, how we determine it, and how do you relate it back to where that is in the patient. The second major type of cancer is what we call an invasive lobular carcinoma. A little less common than the invasive ductal, but it's still a truly invasive cancer, but by definition, it's one that doesn't form ducts or glands. It arises from a little bit different area. Okay, it arises from a little bit different area of the breast lobule, but it is still from the cells that line those ducts. And the way it grows is it grows in these cords, and I'll show you one other higher power image. It grows in cords, sometimes single cells. This can be very subtle, difficult to see, but you may hear about this as being another type of cancer, an invasive lobular carcinoma. One of the other things pathologists will look for, and you should also look for and ask about in your pathology report, is the presence or absence of what we call lymphovascular invasion. Remember, in the beginning, I stated that ductal carcinoma in situ, it's completely contained within the ducts, has no access to blood vessels that are outside of the ducts. Blood vessels are the transit system that cancers will use to travel to lymph nodes or other organs within the body, and what we call metastasize. So we will always look for the presence of, do we see tumor in blood vessels? And this is an example of cluster of tumor here. There's three clusters here, 1, 2, and 3, and you can see it's within a space, and these spaces are actually either small blood vessels or lymphatic channels, meaning the tumor has gained access and invaded into these vessels. And where do these vessels go? The first stop is usually the lymph nodes, and the lymph nodes are an equally important criteria to know about in a pathology report. Is what's the status of the lymph nodes, because as we'll see in a few minutes, that factors into the staging for a cancer. Here's a picture of a lymph node, sort of tracing out the border of it along here. A lymph node is a collection of lymphocytes, and those are all of these small dark cells here at the top of the screen. And what lymph nodes are basically small filters throughout the body, and they filter out bacteria, viruses, any sort of foreign invaders into the bloodstream. They filter out dead and dying cells, and a very important function is that they act as a filter and a checkpoint to try and stop, if there is a cancer there that's invaded into the vessels, to try and catch it and stop it there. And this is an example of a lymph node. The remaining lymph node is up here, but down here, where I'm circling, you can see my cursor, is all tumor cells. And some of them here have even, you can see them forming glands. So they're trying to form the glands that they were growing as in the primary site, but this is what a positive lymph node would look like, and that directly impacts the stage of the cancer that we will report out to the treating team, and we'll go through what I mean by staging. There's a lot of criteria that we assess when we look at the lymph nodes, and whether we find a metastasis in the lymph node, we will classify it based on its size, whether it's a small metastasis or what we call a micrometastasis, or a macrometastasis, a larger metastasis. And those will be reported in the pathology report. The other major thing that we assess on all new cancer diagnoses is the status of its estrogen, that's ER, estrogen receptor, progesterone receptor. So those are the hormone receptors. This is assessing, is the tumor ER positive? Does it express estrogen receptors or progesterone receptors or both? And the third one is HER2, which is a gene that we've discovered in a while back, and have found that that's an important prognostic feature as well to know about. And I'll show examples of each of these. In contrast to the images that I showed previously, where you saw differing shades of purples, pinks, blues, reds, we can substitute those dyes with antibodies. And this image here is taken with an antibody for estrogen. Estrogen is localized in the nucleus of the cell. So the brown here is staining nuclei of a well-differentiated cancer. You can see it highlights almost every single gland here that's malignant. And this would be classified as a estrogen positive tumor. Progesterone shows the exact same pattern of staining, and that is then reported as either positive or negative, and the percentage of cells that are staining as well. That is important information for the oncologist to know, because some tumors may be estrogen negative, some may have low level estrogen expression, and that's going to impact choices of chemotherapy if chemotherapy is needed, and or estrogen therapy, such as agents like tamoxifen, whether those can be used or should be used, and whether they would be effective or not. So a cancer that's estrogen positive would benefit from a drug like tamoxifen. HER2, we always will stain tumors for the presence or absence of HER2 expression. And in contrast to the estrogen slide that I just showed previously, the HER2 localizes in the membrane of cells. So instead of seeing the round dots of the nucleus here, we actually see the outline of the cell membranes. And this would be scored as a HER2 positive cancer. We grade them as 0 for negative, 1+, 2+, or 3+. This is an example of a 3+ or a HER2 positive expressing tumor. And the importance of that is that this opens up a whole other line of therapeutic options for the oncologist. Drugs such as Herceptin, that is designed specifically to target HER2, and you can see why it would be effective. All the brown here is the HER2 molecule sitting on the cells and susceptible to the Herceptin medication, or there's now other generations of Herceptin like antibodies that will target and are very, very effective in treating HER2 positive cancers. So definitely ask for a pathology report. If you've recently had a biopsy, or you know someone, friend or family member that's had a biopsy, ask to see the pathology report. You'll want to know about that tumor or abnormality, and every one of those criteria we went through should be in the pathology report. So we should see a diagnosis, meaning that's the final diagnosis. We should see, you'll probably see something called the gross description, which is just the pathologist will describe what the tissue looked like before we cut into it. and then there'll be a description of what the pathologist saw under the microscope. They may include what's called a synoptic report, and that is a listing of all of those elements I went through, such as lymph node status, whether there's lymphatic invasion, estrogen status, the grade of the tumor, the type of tumor. All of those are required to be in the report. You should look for them. And there's oftentimes a comment section where pathologists may discuss a difficult case or some nuances about the case that why they diagnosed something the way they did. The College of American Pathologists is our governing association for board certified pathologists, and they put out these criteria, these checklists that all pathologists should follow when they're making these diagnoses. And this is actually a handout that they offer. It's online, and it's directed towards patients. If anybody wants a copy of this, it basically goes through and breaks down in a sample pathology report these different categories, what each one means, and it's very helpful. If anybody wants a copy of it, I can you can shoot me an email after the conference, and I can provide you the link to that. I wanted to finish up here by talking about the multidisciplinary team or the tumor board. You'll hear the term tumor board, and what that implies is nowadays the model of care is that of a multidisciplinary team, meaning everyone will meet around the table, from the pathologist who's sitting here at the front with the microscope. They'll project the image that I just showed you up onto the screen, and the other attendees here are typically the oncologist, the radiologist who will show the mammogram and other imaging. A surgeon might be present, radiation oncologists, nurses, support nursing staff as well will be in attendance, social services, everybody, patient navigators, everybody who's going to make a decision, who needs to know about the patient is there. All of the data is presented, your pathology report, all of the imaging, all of the findings, and then a recommendation will come out of that tumor board for the next step. And what's gaining popularity now is you've likely heard this in the press, is precision medicine. And what precision medicine is, I'll go back to that, is if we take tumors and we can actually put them on an instrument here and look at the DNA of that tumor, figure out why it is abnormal, what its mutations are, and hopefully be able to enroll that patient in a trial that is designed specifically for their particular tumor. This is a sort of a change in the paradigm of how we used to treat cancer in the past, where a patient may get chemotherapy that targets all dividing cells in the body, and that's what often gives a lot of the side effects of chemotherapy, is because it's not only hopefully targeting cancer, but it's hitting innocent bystanders as well, the GI tract. So there may be nausea, diarrhea. It can hit the bone marrow, and there can be low blood counts as a result. Nowadays, what we try and do is this precision oncology or precision medicine. We try and find out where that tumor's Achilles heel is and try and just target that particular region rather than hitting all dividing cells. And one way that helps us here is, you may have heard about Oncotype. This is a study that looks at the tumor and determines by analyzing 21 different genes in that tumor what is the risk of that tumor coming back. That you'll see a recurrence score here. what's the risk of a distant recurrence or a metastasis? What's the risk of that tumor traveling into the lymphatics and presenting down the road somewhere else? And is there a benefit from chemotherapy? And that's the main purpose of the Oncotype test, is determine in early stage breast cancer, and even ones that have some positive lymph nodes, is there a benefit to additional chemotherapy after they've done surgery and gotten the tumor out? So that's another report you may hear about. You can definitely ask about if you're eligible for Oncotype testing, and if so, what did the results show? The final thing here is staging. So all of those criteria that I went through earlier here go into what's called the TNM staging. T stands for tumor size, N is the nodal status, and M is presence or absence of metastases. And each one of those letters gets a different score, and based on that, a stage is established. And this is just a screenshot of the guidelines that are put out by the National Comprehensive Cancer Network, NCCN. This is something you can absolutely ask your oncologist about. What was the TNM grade and the score, and what stage does that correspond to? These NCCN also issues treatment guidelines. This is just one screenshot here, and this is exactly what gets discussed at our tumor boards. Is okay, where does this patient fall into the matrix here based on their TNM score, and what are the treatment options for that patient? And this is just one screenshot, but there are several pages of this for the various combinations of the particular tumor characteristics. So I'll just finish here by going through some key points that definitely everybody needs to know about their pathology report. Is ask questions to first get the pathology report, know about if there's been any lymph nodes removed, what did those show, know what the tumor size is, because as you remember, that factors into the TNM stage, whether there's a presence of vascular invasion or not. This is a major prognostic factor for patients. Patient age, histologic grade, was it a well-differentiated, moderate, or poorly differentiated tumor? The particular subtype of the cancer, I didn't go into all these different types, but the invasive ductal cancer that we showed, the most common type, it does have different subcategories, and some of those do have some significance, so you can ask about that. Patients will sometimes have what's called neoadjuvant therapy, where a cancer is diagnosed, and neoadjuvant means that they may get chemotherapy and or radiation before surgery in an attempt to shrink the tumor down and what we call move the stage down, so try and de-stage it down to a lower level stage. Know about your ER/PR status and also your HER2. I didn't add that in there. Oh, it's right here. Those are the key elements that everybody should know about a breast cancer if they have one, if their family or friends has cancer. Make sure you know about these. Pathologists are happy to help answer some of these questions, and definitely your care team will want to hear your questions as well. If you guys have any questions, you can shoot me an email. Here's my email address, and I want to thank you very much. I think we're coming up to the end of the hour, but we do have a few minutes if anybody has any questions.
Thank you. And we do have a question that came in regarding that multidisciplinary team. Is there a reason why patients are not part of that meeting after the diagnosis so they can get a better understanding of their report and the recommended course of treatment?
That's a great question. I think there are a few programs across the country where patients will be invited to come in. I can remember one time, I think, in several years where a family member wanted to attend and was present during it. It's definitely not the norm right now, but I think as medicine moves towards a shared decision-making model with patients, I'm a firm believer that patients should know as much as they can about their disease and share in that decision-making. And I think that's a great opportunity and definitely something patients should ask their providers whether it can be done or not.
Okay. And what can be done proactively in the primary care assessments? It sounds like scans can be done, but is there a reason why this is not more regulated or recommended?
As far as the workup for breast disease, I'm assuming, or whether patients can participate in this, you know?
In the initial workup.
Yeah, so definitely ask your provider what the guidelines are given your age, your family history. Those are perhaps the most important criteria to know about, whether there's a history of breast cancer, what types of breast cancer, and what degree relative that cancer is in. And if you know of any genetic abnormalities within your family that predispose to cancer, such as everybody's heard of the BRCA gene. So we commonly test for that. That also brings up a whole other discussion about genetic testing, and that's definitely something that needs to involve the patient. So definitely ask questions of your provider about whether you might be a candidate for genetic testing.
Okay, I have another question that's come in about lobular carcinoma. It's often missed in mammograms. Are we any closer to having a better screening tool?
Yeah, so that's a good question. So that's a very well differentiated cancer. As you can recall, the very first image I showed of an invasive cancer, it's one that forms tubules, and it's often very hard to diagnose pathologically. Sometimes pathologists struggle with it because it can mimic normal breast, but it still can present abnormalities that are detected on mammogram. And I think the thing I would add is that 3D mammography has really revolutionized the screening process and has led to picking up a lot more cancers, both ductal carcinoma in situ and very, very early cancers such as tubular carcinomas. So if you don't have 3D mammography, definitely ask for it. Any other questions?
Yes, I think as we're coming up on the hour now. So Dr. Misialek, I want to thank you so much for being with us today for this informative discussion. On behalf of Cheryl Osimo, MBCC's Executive Director, and our Board of Directors, thank you. And we want to thank all of our listeners for joining us today. If you have additional questions, I invite you to please follow up and with us or with Dr. Misialek directly, and we'll make sure that we get answers to you. For those of you who are interested in listening to the recording of this webinar, it'll be available later today on the MBCC website. So thank you all so much, and have a good afternoon.
Thanks, everybody.